Sweet. Yeah, I got this whole view, so as long as you're right here, we're fine. So, welcome. Appreciate, of course, most of you are a captive audience today, right? For a while, anyway, until the tones and stuff go off. Traditionally, so for those of you that haven't gotten the chance to meet Dr. Is there anybody that hasn't met Dr. Oraskovich? Look at that. Yeah. Wow. And keep in mind that we're hiring 15 to 18 more, so these guys are all going to be veterans soon. Okay? Anyway, Dr. Oraskovich is, of course, our medical director. He is unquestionably the reason that we have the medical program that we have here. He brings so much credibility to our organization. He's been with us for about 24 years now. In that time, he's seen us go from our ambulance operations to adding paramedics, to adding RSI. During that time, he was recognized by the Bureau of EMS as EMS Physician of the Year. He was also, for a spell, Murray Fire Department's medical director also, and at the time was working for the physicians group that covered Intermountain Medical Center, the trauma center down there, and you spent what, about 15 years? 17 years there. So incredibly well versed in the pre-hospital environment, the trauma environment, was recognized also by the Bureau of EMS and achieved a Lifetime Achievement Award from the Bureau of EMS for his contributions. He sat on many committees for the Bureau locally. He shaped not only our EMS care, but EMS care of what now paramedicine looks like in this county and what EMS care looks like in the state and beyond. He's part of the, occasionally, not as much as we used to be, but part of the National Difficult Airway faculty, the National Difficult Airway course faculty with myself. There's nobody better to have as our buddy and as our medical director, and so we're really fortunate that he's here with us today. And I threw him a curveball because it's Airway April, right? And in the past, he's always come and spoken about airway topics. And this time, though, with the number of new people that we have, with the addition of Image Trend to our documentation, to the switch to Image Trend, I really felt like, and the administration felt like, it was time to look at documentation again, all right? And so I asked him to come talk about that, and he was, as you might imagine, overjoyed at the prospect of teaching about. No, actually, he was very gracious, and he actually said, ironically enough, it's kind of a passion of his. So we couldn't have picked a better person and a better topic. Please do two things with this: not just listen and pay attention like I know you're going to, but more importantly, think about how you do your reports. I know when you've had a busy day and you've got 3 or 4 stacked up, it's very easy to mindlessly go through your Image Trend narratives and your Image Trend reports. Until years later, and I know he's going to allude to this, Steve Garsides, the attorney, says, hey, I need to, actually the first phone call comes from the assistant chief, and he goes, hey, I need to talk to you about an incident you were on 3 years ago. And your heart rate will be like, oh shit, right? And then that begins the cascade, which ends up in the legal office, where you begin going through depositions and all reviews of your paperwork and stuff. And if you've not yet had that pleasure, have you? Yeah, it's fun, huh?
Yeah, it was probably 6 years ago, and we got rocked that night. And when I pulled my report, I was so happy that it was as good as it was.
So I've been deposed twice on incidents, well, here at Layton. And both times my narratives were written by my partners. One time my partner wrote such a good narrative about the incident, it was actually a police brutality complaint that we were on, that our patient was actually the one that had decided to take on the cops, lost, as you might imagine, and then claimed police brutality. It was because of my partner's documentation at the time that entire complaint got thrown out. Not even the PD's documentation, ours. I had another occasion where I had a partner not do the best of documentation, and it was a little tenuous. I'm not going to lie to you. It's frightening. So this stuff matters, and it's stuff that we gloss over because it's not the sexy part of what we do, right? But I will tell you, especially as you gain a little bit of gray hair and a little bit of wisdom, this stuff matters. And so we're fortunate to have Dr. O present and talk about it for a spell. And then when he's done, please talk to him about any other questions you might have or what his thoughts are about our maybe the change of paramedic delivery in the county, or anything you might have, please share with him. He's here with us. For those of you that haven't seen, we show up on scenes occasionally when you're on duty, when he's here. We try to get him out and interacting with the crews. It's good. So anyway, Dr. Owen.
Thank you, Jason. I can't do this without giving thanks to Jason. Those of you who have recently joined the fire department here and have not met me before, Jason is my right-hand man. I don't think any of the accomplishments that he has mentioned would have been possible without Jason helping me, directing me, writing some of the protocols, and having the backing of administration, of Scott and Kevin. You guys work for a very special department here in Layton. The backing, the funding of the city is bar none, I think, the best you're gonna find in the state of Utah, if not in the country. Administration has your backs, and having worked for other departments, when it came time to trim back my EMS commitment, I settled on Layton to finish out my career because of administration, because of the quality of the training we provide here and the quality of care we deliver. It's bar none, I think, the best I've ever seen. So kudos to all of you for continuing to achieve that mission and deliver on it, because it makes my job a hell of a lot easier. Jason asked me to talk about documentation. I put down what you do matters. How many have heard that before? That's common statement in emergency medicine. What you do matters. What you do makes a difference in people's lives. I just want to expand further on it. What you write down matters just as much. When all is said and done, when the dust is settled, the only thing that's there to describe what you did, what you thought, is what's in writing. Everything else is hearsay. Everything else is conjecture. It's stuff that you're relying on your memory or somebody else's memory. But what was written down at the time of the encounter is the definitive record, and that holds more weight than what the patient remembers, what the family remembers, what anybody else on scene remembers. So that's why this is so important. Remember that you've risen to the ranks now of a medical provider. You are a professional. And with that comes a responsibility to use good grammar when you're documenting, use good punctuation, use good sentence structure, and make sure when you're signing off on that note that what you put down in writing makes sense, that others can essentially get a picture of what you were thinking about when you were on scene with that patient. What did that patient look like? I want to be able to read your note and feel like I'm sitting on your shoulder looking over you at the patient and have a really good idea of how sick that patient was, what their injuries were, and why you did what you did. I think of documentation as being a salesman. I mean, you're selling that patient. You're selling your opinion of what's going on with them, and you're trying to convince somebody else that what you did was the only thing and the right thing to do at that point in time. I think we'd all be surprised to know how many people actually read our notes. A lot of us, especially in EMS, you think, well, we don't deliver the notes to the ER anymore. Hospital doesn't care. They're not reading the note. Nobody, I mean, I'm just documenting this for the sake of documenting it. It's a menial task. You'd be surprised at how many people go through the notes after you've written them. And we'll kind of go through who looks at notes in this lecture. My point here is to talk about who's looking at your notes and why they're looking at them. What are things we can do better in terms of how we document? What are the key areas, the most important areas to focus on? What are mistakes that we make over and over? What are the tips that we can do better? And what are the high risk ones? What are the ones that are going to come back and bite us down the road? So that's kind of an outline of what I want to cover in this lecture. I'm always surprised at the power of our notes. Jason mentioned that I take this personal. I would say there's not a month that goes by that I don't hear from one of my colleagues who pulls me aside and tells me how impressed they are with the way I document. And I've taken, I've done this for 27 years, so I've refined it over the years, but I take it very personal in terms of the quality of my documentation. I want to sell myself in terms of why I did what I did. I want that person reading my note to know what other things I thought of and either ruled out or ruled in. Even my wife comment, maybe she has a duty to comment in a positive way, but usually she doesn't. Just said the other day, I read one of your notes, and I had a perfect idea of what you were thinking when I read your note. I knew exactly what was going through your mind. And for me, that's what I need to convey to the consultants. I need to convey to the people who are following up the patients. For you guys, that's what you want to convey to the medical professionals who are reading your notes, the legal team. You'd be surprised how many of our cases, police incidents, motor vehicle accidents, that go on to legal. Not legal against you guys, but legal proceedings because whatever happened to them has some legal consequence.
Mark, can I interrupt you real
Yeah.
quick? Scott, how many a week do you think we're getting requests for?
Usually over 5, sometimes up to 10 per week.
5 to 10 of ours per week through legal, so. Okay.
That's impressive to think about.
Yeah.
How many people are requesting our charts and reading through. And again, I said in the beginning, be a professional. You're a medical professional. You've trained, you have a special skill set, but with that comes a responsibility. And part of that responsibility is to be thorough and I like the word eloquent in your documentation. Rise to that level of being a professional because that's what you are. And your documentation should not reflect a second grade level of writing. It should reflect the level of a professional who's good at what they do, who's confident at what they do, and is thorough. When Jason told me to do a lecture on this, I thought, okay, this is going to be about as exciting as watching paint dry. This is not a topic that really garners a whole lot of excitement. If you look at the list of things we have to do, documentation is not high on the fun scale. Putting in a chest tube, venting a chest, reducing a fracture, trauma resuscitation, a gunshot, the things we get excited about, documentation, I would say, is very low on the list. But I would also say that on the importance scale, it's second only to the level of care you're giving the patient. Because all that there is at the end of the day is what you wrote down. We've all heard the saying, if you didn't write it down, what?
It didn't happen.
It didn't happen. I've been in many illegal proceedings over my 27 years, some because I was at fault or thought to be at fault, and others where I'm just defending somebody else. But it's humbling to sit on the other end of a legal table and open up your note and not be pleased with how you documented that encounter. Immediately seeing the omissions that you wish you would have put in. It makes you become better at what you do when you are in that kind of situation. And so the best way to avoid it is learn the right skills now and practice the right skill set going forward. And when you do find yourself at the other end of that table, be happy and thrilled that your note reflects all the important points that need to be conveyed. The system we use, Roxanne was just showing me an image trend chart. It's a lot of checkboxes. And I think checkboxes are a great way of collecting data. It's a great way for the bean counters. It's a great way for the billers. But it doesn't always paint a nice, coherent picture. So I'm going to put a lot of emphasis here on the narrative. Because what I want when I read your note is I want to get a picture. Like I said, I want to be sitting on your shoulder, looking over it, getting a picture of what was going on. And I think the narrative section is really the key to that. I think that's where you're painting a picture of exactly what you were thinking and defending what you did. That's where you're the salesman. I get it. All right. A lot of us think this way. I'm already doing a good job. I got this. This is not that difficult. And I'm here to tell you, you're not that good, because I read your notes. I'm not that good. There's always room for improvement. The goal here is really just to point out those areas that we have room to get better on this. What things affect the quality of our notes? What are some factors?
Maybe being fatigued at
Fatigue,
times.
perfect, yeah.
How important we perceive what was happening. We tend to minimize stuff that we probably ought not.
I mean, if I know exactly what's going on with a patient, somebody comes in with an ankle sprain, I've got a pretty brief note. I know the key things I need to hit. I gotta document a vascular exam. I've gotta document a neurological exam. And I gotta describe where they're tender. And there's also a list of things in my mind that I also have to document that are negative, that they don't have knee pain, they don't have hip pain, I'm not missing something else. But that note is pretty brief and succinct. It's not one I'm worried is gonna come back and bite me. Now, the notes that become much more verbose and long and detailed are the ones where I've got no freaking clue what's going on with the patient. Or really high-risk complaints. What's a couple of high-risk complaints? Chest pain. Belly pain in an elderly patient. Neurologic complaints. God knows, neurology takes all shapes and forms, and a lot of things we think are just plain psych end up in some way being neuro. And those are things that come back to bite us. So those are areas I'll have a more detailed note and a longer note and expand on what I was thinking and why I did what I did. Time of day. When you're documenting at 3 in the morning, what's the first thing you want to do? You want to get back into your bed and get some rest. So you're not really focusing on your documentation as much. Fatigue plays a role into that. How busy you are on that particular shift. So we'll cover the areas that I think are most important and where I really want you to focus your efforts, and an area that I think we can all improve on. Patient reported a headache for 3 hours. All right, who knows what's going on with this patient? It's kind of wide open, right? I mean, give me a couple things. What could that headache be from? Just give me one diagnosis.
Caffeine withdrawal.
Caffeine withdrawal, great. I get that on a regular basis. Hangover, there you go.
Stress.
Fatigue, stroke, head bleed, boy. You've given me their patient complaint, and this is, I think, one complaint I would have with Image Trend is when you're doing patient complaint, you kind of either check from a checkbox or you write in a couple of words what their complaint is, but really hasn't given me an idea of what's going on with the patient. And I don't expect you to know that every time, but I expect you to know the things that could possibly be going on with that patient. Because that affects how fast you're going to get to the hospital, which hospital you're going to go to, and which interventions you're going to give that patient. Same patient, a little more detailed. Headache began at 2:20, watching TV, unaffected with any change in position or bright lighting. Well, now that note gave me a little bit more insight. They weren't doing anything in particular. It just came on all of a sudden. It's probably not a hangover. It doesn't seem to be bothered by bright light, so maybe it's not a migraine. I've narrowed in a little bit more on the possibilities that are going on just because of the thoroughness of the documentation. So again, this would be in your SOAP format under your narrative. Headache began at 2:20 while watching TV, unaffected by change in position or lighting, described as a thunderclap headache or sudden onset headache, worst headache ever. Threw up twice in 10 minutes. Roommate says she's really tired. Chest pain, difficulty breathing denied, recent head trauma confirmed, recent motor vehicle accident. Nobody evaluated the patient afterward. What do you think's going on now? Probably a head bleed of some type, sudden onset, maybe a subarachnoid bleed. But you notice how just that level of documentation narrowed you down on that diagnosis and conveyed to the person reading your note that you had a pretty good idea of what's going on. I would say 90% of my diagnoses are from the history section, from the chief complaint, mechanism of injury, and the history of present illness section. Physical exam adds, I don't know, 10% maybe. It's important, but a lot of times Brittany is my PA who's working with me this month, and she's joining us today, and she probably sees it in the room. I've already kind of made up my mind what the likely top 3, top 4 possibilities are by the time I've talked to the patient, and I haven't even laid hands on them. Sometimes I'm just laying hands on just for the show. So the patient feels like they had that physician encounter and we actually examined them, where I've already kind of made up my mind what's going on. So, history of present illness, chief complaint, one of the most important things we should be documenting. Who reads our notes? Does anyone read? Does the hospital get a copy of your note?
They can get access to it, yes.
They should be. How many worked in the days where we just gave them a pink copy?
Mm-hmm.
Yeah, I loved that. I love that because I could see what meds you gave. Half time I couldn't read the writing on it, but I could at least pick out some of the details of what's going on. So people that read our notes, healthcare providers I put at the top of the list. So the hospital that's receiving your patients, the doctors that are caring for the patients in the ER or afterwards, the therapists who are caring for the patient afterward, the care home maybe that they went to after that encounter. But there's more than that. There is the billing folks. If we're not doing a good job documenting, we're not doing a good job capturing what we did. We're not doing a good job recouping the costs or the opportunities for income, then we don't have an agency that exists. I mean, the world revolves around money. And for us to have the equipment and have the staffing we need to recoup the costs of what we're doing so we can continue going forward. Quality assurance, this is where I come in, this is where Jason comes in, this is where we're looking at your notes to see if they met that standard of care. And to look at the note and say, okay, what areas should we focus our training on? What are we lapsing on? How many have been involved in a review of a complex case? Either an airway case or a trauma case. How many have had a case reviewed? Boy, not a lot. I have a lot of my cases reviewed, I don't know. But
Maybe talk to them about how frequently we hear from physicians with questions about care that we've gone back and looked at that.
I mean, it's every month.
Yeah.
Every single month, I get a text from Jason where there will be a physician who'll say, hey, why did you guys call that in the field? Or why did you use an epinephrine drip on that patient? Why did you spend so much time on scene on that patient? Why didn't you go directly to a trauma center on that patient? And your note is my window into what you were thinking and your defense of why you did what you did. And the more thorough that is, the more I can defend you if they're coming after us as an agency. And I would say 9 times out of 10, when I've read the note and talked to the crew, the complaint is dissolved. It's gone by the wayside. They have a better understanding. And some of that comes from the fact they don't get a copy of our notes anymore contemporaneously at the time of the encounter. How many have frustration with the verbal report at the bedside? Either feel the doc isn't there listening or not paying attention. Has anyone had that? Yeah. I try to be the doc who makes a special effort to be there when EMS is handing off and to give you the time you need to give your report. Now, that should be 59 seconds or less. I want your report to be complete, succinct, but to the point so I can move on and do my exam of the patient. But what you do is important, and what you do deserves to be heard by the providers in the ER. And if you're not getting that, then I'm the one that should hear about that, because then I need to go back to them and have a conversation with the ER that we're not being heard, and there's vital information that's then being missed. Let me give you an example. I was working at Intermountain Medical Center. My partner and I were in the back zone, and EMS brought in an unresponsive patient who was seizing, completely unresponsive, had no idea what was going on with her. But the paramedics told me this. They said, we found her alone in her apartment. It was, I think, February or March. All the windows were open in the apartment. There was a plastic sheet on the floor. These were the pill bottles we found on scene, and all of them had carefully had the labels torn off of them. And she's laying there unresponsive. What does that start to paint a picture of? Yeah.
Suicide.
Here's somebody who really was making a strong effort to try and take their life, and didn't want the apartment to smell, didn't want people to know what she took. Turns out she was a nurse. She was going through an ugly divorce. She had sent her children away for the weekend. And this was a very, very premeditated act. And so I was in there with the crew and said, you know, what else did you see on scene? What else was helpful? Was there anything else that could help us? And we did some quick labs at the bedside, and she came back with a bicarb level of 3. So she's in a severe, severe metabolic acidosis. Any thoughts? What could give you a really severe metabolic acidosis? Diabetics can have one, DKA. There's a mud piles mnemonic we go through in medicine when someone's acidotic, and on that is toxic alcohols. Methanol, ethylene glycol. You would think nobody drinks a gallon of ethylene glycol or antifreeze. But I asked the medics, I said, can someone go back to that house and search that house and look in the garbage and see if there's anything there that might explain this? And so they went back and they found a gallon of antifreeze in the trash can that was empty. So there's a case where what that crew, they didn't document it, but they told me, but we're not always in the room, made the difference in the patient's care and saved her life. Because if we wouldn't have gone down that pathway, I wouldn't have made the right diagnosis. Legal defense. I mean, I don't like to say we document for legal defense for their benefit, but for our benefit. And it's like Jason said, when you're sitting at the end of that table and you look down at your note and you breathe that sigh of relief, oh, thank God, I really described this well. I really described the physical exam well. I really understand what I was thinking. Because chances are, when you get that phone call, it's not 2-3 days later, it's not a few weeks later, it's months later, and probably more likely it's going to be years later. And you have no clue. You have no physical memory of that case. The ones you get called on aren't the ones you're usually worried about. It's the ones that hit you by surprise. It's the ones that you thought were a slam dunk, and all of a sudden it's like, what? Wow, why did they have a bad outcome? Wow, I must have missed something. And when all you have is your note to go back on, you're pretty thankful that you did a good job the first go around. All right, 5 reasons to do better documentation. This is just a reiteration of what I just went through. These are the categories. Clinical, the healthcare providers that are reading your note. Again, what you write down is the only record of what you were thinking, what you did, and what happened. Anything else is just hearsay. Be objective. I think we have these type of cases that rub us wrong. The frequent flyer that we go on a lot. The person who's just drunk, again, that we're going on. The fall. And sometimes we let our biases creep into our notes a little bit. And I want to really caution you to not do that. Don't document, we're on the scene of another, this patient, they're drunk again. This patient called EMS for the 14th time again. They want to be transported. Doesn't look like anything's wrong. When you put that in writing, and that happens to be the one time that patient really does have something wrong, it's gonna come back and bite you. And you're gonna be awfully embarrassed that you put that in the note. So I would say the note, what you're gonna put down is objective. It's what they're telling you, it's what the family's telling you, it's what you're seeing, and don't include a lot of opinion in there. I mean, in your narrative, I wanna know what you're thinking is going on, but I don't need the extraneous stuff, and I think it can only hurt us. And I had a case a couple of weeks ago of a guy who came in who was just weak and dizzy, old patient. And you're just like, weak and dizzy, yeah, this could be all, he was sleepy. And I started my note and started putting some stuff down. And then it kind of hit me that, oh, this guy has myasthenia gravis, which is a pretty rare condition where people get weak. And it turned out, in the long run, this guy was in a myasthenia gravis crisis with impending respiratory failure, possibly needing a ventilator. And I looked back at how I documented that first part of the encounter, and the note wasn't done yet, and I erased a lot of what I wrote and redid it, because it wasn't reflective of really what's going on. Here's a case that in my mind I thought, oh, this is just another weak and dizzy. Why, for God's sake, did he call the ambulance? Come on. In reality, he was in a life and death situation, and as I uncovered that, I should have been much more objective in how I wrote the note. Here's a guy who's weak, he's having trouble getting around, he's had this before. By the way, he has myasthenia. And probably it's just my depth of knowledge. I've never seen a case of myasthenia crisis in 27 years. And when I read up on it, it was like the textbook smacked me right in the face, like, oh, wow. Should have seen that one coming if I would have read a little more. Be prompt and efficient in your notes. Does everybody do their notes within 24 hours? Is there ever a time we go beyond that in finishing the note? I hope not. It's looked at when the case is reviewed by an attorney as to when that note was signed off. Because the longer the time frame when you finish your note and when you had the patient encounter, the more chance that you have more information about what happened at the hospital or the patient died at the hospital. Therefore, more chance that you could modify your note to make it look like what you did was just perfectly right. And that then puts the whole validity and integrity of the note into question. So, notes that are done contemporaneously at the time of the encounter, rapidly after, have the most power and the most integrity. And it's okay to go back and add an addendum to the note, but be real careful what you're putting in that addendum, why you're putting an addendum on, and not doing it days later. Because that's looked at really carefully. Accurately diagnose your initial assessment. This is your exam. I want to get the exams we do are focused. If someone has chest pain, what are the most important areas to document for an exam? The
Location, radiation.
Yeah, so that's the history, but on the exam part, what are you going to be looking at and listening to? The breath sounds, the heart sounds, the pulses. Those are the positive findings. Did they have rails? Do they have labor breathing? Is their skin clammy or sweaty? But I would say it's also important to document the negatives. If somebody's got chest pain radiating into their back, going into their flank, I also want to know, were they tender in their belly? So documenting that they did not have abdominal tenderness. Or if it's a stroke, I might want to know that their speech was perfectly clear and coherent, or that they're moving everything equally. So being thorough in how you document your assessment, and some of that comes with understanding what the diagnosis is, or what the process is that's at play, and what we should be thinking of. If it's chest pain into the back, you should be thinking of a dissection or a AAA. If it's somebody who can't move an extremity, you're thinking stroke. So document what you find, but also some of the things that you did not find. Document your interventions. This is pretty straightforward. It's all checkboxes on ours. What we sometimes forget is documenting what the patient's response was. You gave albuterol. What did their lungs sound like 10 minutes after you gave the albuterol? They're in anaphylaxis. You gave them epi. What did they look like after? How many have had anaphylaxis cases that really went south? The kind where your sphincter just tightens. I had a case about a year ago, maybe not even that, of a young girl who ate some cashews on Jordanelle and had an anaphylactic reaction, no nut allergy. And she had an EpiPen, and she took an EpiPen, and she came into the ER by ambulance. And she looked pretty good. She was a little pale, she was tachycardic, her breathing was better, and what they described was pretty nasty. And I thought, okay, we gave an epi, she's turned the corner, she'll be fine. Turns out her dad was one of the Lifeline instructors, and he'd been with Lifeline for many years. And now was, I think, teaching down in Dixie or down somewhere in southern Utah, or maybe it was Utah County. And about 45 minutes, I walked into the room, and she's sitting with Mom, and as I walked in, she was as blue could be. She looked like a Smurf. And she's going, and I looked at the mom did she just, when did this happen? Oh, she just started doing this. Okay, well, let's get her on a pulse ox. Oh, she's 70%. So she rebounded like that. At which point, my sphincter tightened like that. We gave her another dose of epi. I assembled airway equipment. We called for Lifeline. I pulled the dad aside and said, this is what I'm doing. I don't think I have to intubate her, but just in case, everything's here outside the room. She did fine, but when those patients turn, they turn quickly. So it's important in your note to tell me how the patient responded to your interventions and how their condition played out during the transport. Did they get better? Did they get worse? That's the narrative section. I mentioned not bringing your biases into your note. I had a case a couple weeks ago of a chest pain, guy with known heart disease who was having crescendo chest pain at rest, had flunked his stress test the week before. That's a slam dunk admit. And I called the hospitalist down at Intermountain, and he's like, guy was he has high blood pressure. Is his pain gone now? I said, yeah, I gave him nitro, his pain is gone. He goes, oh, you controlled his blood pressure, so his pain is gone, he doesn't need to come in. Like, am I hearing you correctly? Like, this guy has heart disease, he flunked his stress test. He needs to come in. You're questioning my judgment? No, this guy doesn't need to come in. You need to keep him there and do some more tests, and then have your cardiologist consult him. Like, I don't have a cardiologist. I didn't put any of that in my note. I was pissed as hell at this guy. I thought the advice I was getting was horrible. I talked to my partner, he's like, send him to the U. Just go somewhere else. You're getting horrible advice. What I did is I called the cardiologist, and I sold the story to him, and he's like, yeah, sounds like the guy needs a heart cath. I didn't put that in my note. There's no place in the note for petty arguments. It just can come back to hurt you. It never helps you. I just called the hospital, spoke to the consultant. He felt that it'd be worth talking to the cardiologist about this patient. The cardiologist graciously said, send the patient down. We arranged for transfer. Turns out the guy then had a heart cath the next day, had a critical lesion in his LAD, got another stent, and did well. Always be an advocate for the patient. Don't let that other stuff creep into your note. There's just no reason for it. We tend to want to sometimes demean the patient a little bit because we're tired of seeing that patient, or we're tired of going on that call, or the consultant's being difficult, but no good ever becomes of putting that in a note. Just leave it out. This is just a reiteration of the sample and the OPQRST that Jason was inferring when we're talking about how we describe our pain. I want to know when the pain started. I want to know what makes it worse. I want to know what makes it better. I want to know, does it move anywhere else? And when did it start?
Can I ask a silly question?
Sure.
Do you use OPQRST?
I do,
Yeah.
but I don't use the mnemonic per se. It's just so ingrained that when I'm describing pain, again, unless it's so simple. I was walking on ice, I slipped and twisted my foot. I don't need to know a whole lot other than when it happened.
Here's my point of that. So often I find that we learn that in our EMTB classes, right? And it becomes so, we almost de-emphasize that because, oh, that's just kind of a teaching thing. I can't tell you how important, even in critical care, in fact, the sicker your patient is, the more you need to make sure that you cover and use those things. So don't just assume that that's a trite little mnemonic because they taught it to you in your EMTB class. That is not true. Commit that to memory and know how to use it in your assessments because it does matter.
I use it. I mean, Brittany would tell you, 10 times a day, when we're discussing a case, I want to know what made it better, what made it worse, when did it come on, what were they doing when it started, what's the relation to the last meal, does the pain move around, has it gotten better since it started? It's this reiterated over and over and over multiple times a day. And like I said, it's so ingrained in me that I don't think about the mnemonic anymore because that's how I document every note. All right, we talked about clinical, we talked about all the things, the people who are reading our note from a clinical perspective. I don't want to spend too much time on this because I don't want to be documenting out of fear, but I think you want to document a good defensive note. You want to be able to sit at the other end of that table someday and defend what you did and look at the note and feel proud that, hey, I made the right call here. Even though this was a bad outcome, I made the right call. There was a good case as I was reviewing literature from 2002 out of New Jersey of a guy who was beaten up by the police. And EMS was called and had to take him to the ER to get cleared and then to go to jail. And the EMS never documented that the guy had been vomiting after the assault. Guy went to the ER, was evaluated at a community ER, cleared, and then was taken to jail and died of his epidural bleed in jail that night. And they sued everybody, and they sued the paramedics, or that agency, and they were found at fault. And they were found at fault because of failure to document that the patient was vomiting. And we've all heard of the EMS Act that protects us somewhat in our care. The EMS Act doesn't protect you against omissions in documentation. And they said if you had simply documented that that patient was vomiting, that the hospital would have then considered a bleed and done more workup. And the fact that you omitted it contributed to that patient's death, and they lost the case. And I don't say that to scare you, but it's just, again, what you're seeing and observing should be put into writing. Because years later when these come up, you're not going to remember if that patient was vomiting or not. So if it's important at the time, it's important to write it down. I think we really talked about these other issues already. The third is, again, the quality assurance, the data drivers, the information we're collecting. And really the only point I want to make here is be accurate in how you're putting down times, because that's how we're deciding how much staff we have on at any particular time at the fire department. Make sure you're getting all the state requirements for documenting traumas, because that's how we get our funding. A lot of that funding comes through the state. And when we're looking at these from a quality assurance standpoint, we're deciding on where we have lapses in our training. So we're deciding where we focus our efforts on training, what we could do better at. When we're looking at airway, it's like, oh, we're not doing a lot of airway assessment. We're slipping on our lemon assessment on that difficult airway. So let's focus our training there. Or we're not really doing good with our glide scope views. How come? Let's focus our training on that. The last one is compliance, and this is just the things that we have to do for state and federal regulations. But I mentioned the second area here, pay for performance, because this is a big deal now in emergency medicine. My pay is directly tied with how well I follow chest pain metrics, how well I follow a sepsis metric. If a chest pain patient I saw and cared for didn't get aspirin, I get dinged. I actually get dinged on my paycheck for it. If the sepsis patient I saw didn't get 30 cc's per kilo of fluid and a repeat lactic acid level and culture's drawn, I get dinged and my pay goes down. So that's already arrived in medicine. A lot of that came through Obamacare, this pay for performance. And it's coming to EMS as well. And so if you're transporting a chest pain patient and you didn't address that they already took their aspirin and you didn't offer them aspirin, CMS is going to look at that and say, well, they're really not meeting the standard of care for pay for performance, therefore we're not going to pay for this call. Scott, what would you say our percentage of reimbursement from Medicare is?
I don't know on Medicare per se, but overall after our mandatory write-downs, we're about 53%.
Wow.
And
How many of our billing requests are rejected, would you say? What percentage?
We'd have to ask Veronica about that.
Okay,
She could come in and tell us if you want.
that's okay, but again, what you're documenting has to be defensible. You have to prove that medical necessity. For Medicare, you can only transport if you're providing care that couldn't be provided by them, just a family member driving them. You have to be offering them something. Their condition, the situation or the clinical scenario they're in, or the interventions they need only can be provided by you. Otherwise, that bill can be rejected.
We get a lot of those rejected,
Mhm.
and if we haven't told the patient that this is not medically necessary, have them sign for it, then it also says not patient's responsibility.
Interesting. I mean, do you guys use a form when you're doing interfacility transports for medical necessity? Because what are the components? They have to be either bed confined, non-ambulatory,
There's a whole list.
Yeah.
There's like 10
need
different
oxygen,
elements.
need IV fluids, need meds, need monitoring, need suctioning. We're not there out of just convenience for people because we're not going to recoup the costs, and we have to convey that to people too. All right. How many use a SOAP format in their narrative? Handful. For the rest, how do you do your narrative? Just curious. Do you just kind of do it as a free-flowing narrative?
Chronological.
Chronological? Yeah. And pick a technique that works for you and stick with it and master it. Chronological is great. I like the SOAP format too. I like an understanding of what the patient or family described, what I found on exam, what I thought was going on, or what are the things I considered was going on, what we did, and how they responded during transport. That's the crux of it. I put down as the second most important section of my mind is the complaint. This is what we talked about just now with the OPQRST and the example I used of the headache patient. This is an area that really conveys to the person reading your note that you either had an idea what was going on, you gathered enough data to figure it out, you had some clue as to what was going on scene. I mean, the big cases here that this helps on are the overdoses, the chest pain patients, the difficulty breathing, the belly pain cases. There are some where it can be very brief, like an ankle sprain, but there's others where I want more detail, and just put that into your narrative. Meds, allergies, past history, again, don't forget the meds. That's so important to us in the ER to know, especially if it's a patient we haven't seen before, or especially if it's an overdose. I think you guys are good at putting the meds in a bag and bringing them in so we can see it. If you don't know how to spell the meds, just look it up. Don't try to phonetically spell them out, because that's not helping anyone, and it's really just demeaning to your level of skill and training. Be the professional that you are, that other people recognize that you are. We have a saying in ER medicine that vital signs are vital. You've got to address them. If that patient has a heart rate of 140, you've got to address that. I had a patient over in Heber a couple of weeks ago who came in because he couldn't pee. Pretty straightforward. Put a Foley catheter in, drain his bladder, over and done with. I go in the room, all right, we're going to send you home. Oh, wow. His heart rate's 180, that's weird. Went back to the initial notes. Heart rate was 60 when he came in. He walked back in the room. Okay, let's get him on a monitor. Sure enough, he's in a sinus or a SVT with a heart rate of 180. I'm like, sir, do you feel that? No, I feel fine. He has no idea his heart rate is going 180. Completely changed where we went with the care. He got 2 pushes of adenosine. Actually, he got a couple attempts at a Valsalva maneuver. That didn't work. He got a shot of adenosine. He converted, and then I let him go home. But again, vital signs are vital. You gotta address abnormalities in the vital sign, and that should be in your narrative. And repeat the vital signs. If you're doing something that can affect them, tell me how it affected them. If you gave some nitroglycerin, I want to know what the repeat blood pressure is. If you gave albuterol, I want to know what the repeat lung exam is. I want to know what their SATs did. We don't have to document everything. You know, if somebody is there with a leg injury, do I really care what their lungs sound like? No, I mean, you can put down lungs are clear, heart rate was regular, but you don't have to focus on that part of the exam so much as I really want to know what the pulse is in their foot. Do they have sensation in their foot? And what does the leg look like? What does the skin look like? Where's the crepitus? Where is it deformed? That's where the focus should be on that part of the exam. I talked a little bit here about including negatives. We already talked about it, but let me give you some examples. The anaphylaxis patient. Patient is having an allergic reaction. It's important for others to know that you looked in their throat, that they didn't have swelling of the tongue or swelling of the back of the throat, because that's impending airway collapse. It's important to know that the patient with the chest pain going into the back, that you didn't feel a pulsatile lesion in their belly, or that their belly wasn't markedly tender. And this chest pain is masquerading as something else. The car accident, who was wearing a seatbelt, kind of want to know if there's bruising over the belly, that you at least looked at it, even though all the injury is above the head, that they don't have a big seatbelt mark, because I'm going to probably scan them if they do. That person's got a high rate of intra-abdominal injury. We've already hit on this. Dosing, time of meds, response to the meds. We've talked about the narrative. I feel that's the most important part. I mean, anybody can check boxes. Boxes are great for collecting data. It's great for extracting billing. It's great for meeting the state metrics. But the narrative, the free-flowing part of it, is what gives me a picture of what you were thinking, what you were seeing. I should be able to read that narrative and feel like I was there with you at the scene, experiencing the whole call. I should have a picture of what that patient looked like. If there's anything I want you to focus on, it's just writing a little better narrative. Signatures, that should go without saying. Let's go through this a little more quickly. Top 10 mistakes. Poor spelling, bad grammar, improper use. I don't think as a professional there's any role for that. We have so many tools at our disposal to help us with spelling. Do we have other people reread the note?
2 other people.
2 other people do it. It's really the note for the whole crew. No matter who's writing it, it's that crew's note. So everybody should have some say in it, and others should be reviewing it. And if there's omissions in spelling, grammar, make the correction. It looks so much better when someone else is reading it that you wrote it at the level of a professional. And it's in character for who you are. You know, you're not just a medic, you're a medical professional, and you should be documenting at that level. Second most common mistake, the narrative doesn't paint a picture of their true condition. And the headache would be, in that case we put up was a good example. I had no idea what was going on from the first chief complaint, but by the third description, pretty much knew what was going on with the patient. Don't make subjective conclusions or opinions. We already hit on this. That doesn't really have a role in medical documentation. Internal consistencies. I do this a lot because I use a macro. When I do my physical exam, I have a macro. And I'll have a patient who's got a below-the-knee amputation, and I'll put the macro moving all extremities well, good pulses in the feet. And then I'll be, oh, wait a minute, they don't have a right foot. Don't make those errors, they just look bad. You know, the stroke patient where you put in the standard neuro exam, strength equal on all 4 extremities, oh, wait a minute, yeah, they're not moving their right arm. Just be cognizant when you use macros or you're used to checking boxes that you don't miss those obvious physical exam findings, because then it brings the whole integrity of your note into question. It'd be very easy for an attorney or someone reviewing it to go, this person really didn't do an exam at all. I mean, the guy didn't have a right leg, and yet they documented it like they just were checking boxes. Improper addendums, corrections, we talked about that already. If you're gonna put an addendum, do it as close to the time of the encounter and do it for a specific reason. The farther it gets out, the more it's gonna bring the validity of your note into question. And these are addressing medical necessity, which we talked about, documenting the reason for transport, getting the necessary signatures, getting the right miles. Number 5, they're second guessing and making improper assumptions. Patient has leg pain. They seem to be walking fine and had no trouble walking out to the ambulance. Does that need to be in your note? No. It's not gonna help the billing. It's not gonna help the case if that patient ends up having an ischemic leg when they get to the ER. I picked up a case once at Altaview, very end of my shift, 15 minutes left of my shift, 14-year-old, leg pain. I'm like, oh, I'll punch this out like that and I'll be on my way home. I go in the room, she's got a white, pale, pulseless leg. She had a dead leg at 14 years old. Ended up going up, getting fascia. In fact, primary was like, we don't know what to do with this. We don't see kids with this. Send her to the U. I mean, she went in and had thrombolectomies, she had fasciotomies, and then a month later she lost her leg. So, making that assumption and putting it into writing, that's only going to hurt you if that case turns out to be one of those rare outliers and you thought you knew what was going on and you did. Just put the objective data on and move on. 6 tips to improve our documentation. You made a lot of decisions in your care. Document them. Tell me what you were thinking, why you were thinking it. Put it in writing. Paint a picture with your words. I should have a really good understanding of what was going on by just reading the note. Again, that's the only thing that's out there, so. Organize the order. I've already hit on this. Pick a format that you like, stick with it, master it, and put it into your narrative. Chronological, soap format, however you want to do it. Pick one that works for you. Document the response to the treatments. If you gave something, tell me what the patient looked like after. If you gave them nitro, did the chest pain go down? What's the new number? What's their new blood pressure? If you started pressors, what did it do to their blood pressure? If you changed the vent settings, how did it affect them? If you gave them a sedative, did it work? Think about what you're going to write. They talk a lot in the literature about thinking about it when you're on scene. I mean, when I'm in a room, I often have a little notepad with me, and if things come up during that encounter, I'll scribble in the little corner like, make sure you write this, and I'll just make a little note of what I got to make sure I write in that note. Like, oh, by the way, they keep a parakeet, and they have this weird cough. Maybe that's going to be something that might help me down the road, but I should at least put that in my note. Use appropriate grammar and sentence structure. We've already talked about that. All right, we're almost done. High-risk cases. The cases where the patient's scene releases, the cases where we're not transporting, some of those are simple. They're motor vehicle accidents, it's a scene release, it's not a big deal. But there are some that are really, really high risk. And Jason and I had a case that was recently reviewed at my request from AirMed. There was a lady visiting from California who was partaking in a snowmobile adventure up in the Uintas and ran into a tree at probably a pretty good rate of speed. Very inexperienced, never been on a snowmobile before. And had some significant complaints, shoulder pain, a little bit of chest pain. She also complained that she couldn't move her right arm. But But she also didn't want to go by helicopter, and a helicopter was dispatched and came to the scene. And she was worried about the cost. She didn't want her clothing cut off. She didn't think she was probably hurt that bad. But she also was probably minimizing her complaint. I mean, she will readily tell you, I can't move my right arm. I don't have any feeling in my right arm. And my shoulder is killing me. And this was a high mechanism of injury. This was a scene release. This was one where the helicopter landed, evaluated the patient, made a decision on scene to release. I then got that patient who transported by BLS for 1 hour to my facility and arrived with a grade 5 liver laceration, a brachial plexopathy with a paralyzed right upper extremity, scapular fracture, multiple rib fractures, head injury, and a cervical spine fracture. She was a trauma 1. So naturally that case got reviewed, and that then goes back to what? Documentation. Why did you guys release that scene? What did you find? What did your exam show? And documentation maybe wasn't so good on this one. And then this becomes a big learning case. This went all the way up to the highest levels of administration at the University of Utah. Because I just feel it was, there wasn't a bad outcome on the patient's behalf, but by term, again, it was a less than elegant delivery of care by them. I felt RER was less than elegant in how we did it. We were extremely busy at the time, and she was getting lost in the shuffle. It took me over an hour to get her transferred. I got hung up on several times by the transfer center. Those things bother you. I mean, we can be better. We can deliver better care, and we should. So be really cautious of your scene releases. The elderly patient who fell, who just doesn't want to go by ambulance, have a stroke. I mean, document a neuro exam, document their belly exam, document their heart and lung exam, get a good set of vital signs. There could be something potentially very dangerous going on, and they're just worried about the cost, or they're embarrassed because the ambulance is in front of their house. So if you're going to release it, document it well. Those are the ones that really have a high risk potential for bad outcomes and medical legal. The elderly patient, the falls, the weakened dizzies, and some of these traumatic injuries too.
Mark, should you also document that you educated them on the possible outcomes of them refusing your care as well?
Exactly, yeah. And don't be afraid to use it. You know, you may potentially have a life-threatening condition and you may die. When people sign out against AMA, I routinely tell them, you may die. In fact, I've had patients with heart attacks sign out where I tell them, you're probably going to die. You're probably going to die from this. Do you really understand that? Tell it back to me. Tell me what I just said. You told me I might die. Great. Because they have to also have the capacity to understand you. And if they don't, the family and other people who are there have to have that same level of information. Hey, your dad doesn't look so good. He's pale, he's clammy, you know, his pulse is really weak. You probably should go to the ER. I know he doesn't want to, but he may die. He may have a really dangerous condition. Hey, it's no harm off our back to transport it. We get the bill for it. We're an advocate for the patient. And if they end up having something critical and you save their life, wow, we all feel great. That's what we're here to do. All right, I'm gonna just leave you with that. You guys are professionals. You've trained hard to get where you are today. You continually work hard with your continuing education. You try to strive to have the highest level of patient care. I just want your documentation to be at that same level too. I want to be able to read your note, be proud of what you did, understand that you were thorough in your evaluation, you were complete in your decision-making and your thinking, and I can defend you if somebody else comes at us for that chart or that care. That's all I got.
Thank you. Hey, we've got a room of people that are in their 1 to maybe 3 to 5 years of their career.
Mm-hmm.
What advice would you share for these guys about healthcare, pre-hospital care, latent fire specifically? What, just some thoughts from you in general.
I think early in your career, I mean, the term I like to use is be a sponge. Suck it in. We all live busy lives. It's hard to fit in time for more learning outside of work. And sometimes at work, it's so busy and we're tired and we just want a break. But the more you can absorb early on in your career, the stronger your building block and foundation is, the easier it is to build on that as you get experience. That basic level of knowledge. I know there's areas I have shortcomings in that if I would have been more attentive in certain areas in medical school, it would have helped me immensely going forward. Neurology. I mean, there's so many bizarre neurologic presentations. And I don't remember my brain anatomy for anything. But I sure wish I did, because it would make understanding a lot of things much easier. So be a sponge, soak it in. If you're on shift, there's so many podcast resources and quick learning opportunities that you can just pull off on your phone and do a 5-minute review of something, and do it after a case. If you see an interesting chest pain case, just pull it up on a quick up-to-date. I send Brittany all the time to her phone like, oh, we just saw this case. Google it now. Teach me about it. Tell me about this. This patient, I don't know, we just had one the other day, I don't remember. We had something somewhat unusual. And I was like, teach me about that. Because I always, like the myasthenia gravis, I went right to the literature at the time of that encounter. And then when I went home that night, I pulled up everything I had on myasthenia. My textbook in emergency medicine had 1 paragraph on it. But up to date had 7 pages of information on it. And I read it and I'm like, wow, that guy was a textbook presentation. That was such a neat case. And we did the right thing for him. But boy, I could have so easily missed that if I just didn't listen or I didn't pick the right information out of the history. So when you have those cases that are interesting or a little different, get the follow-up from the hospital, see what happened afterward, call the hospital, get some follow-up. They love it. Hospitals love when EMS want to follow up the case. And then read on it. And it doesn't have to be anything in depth, but soak it all up. That's probably my number 1 piece of information. Realize your limitations. I mean, we all have things we're not good at. Embrace the things that you think you're weak at and master them. You know, if it's a procedure, I feel very weak right now in neonatal resuscitation. And the other day, my partner got called up for a normal delivery that seemed to go fine, and 2 hours later, the kid crunked. And as he walked up there, this newborn was in respiratory arrest, and he had to intubate the child, and they ran a resuscitation for 4 hours, and the child died. Normal birth. Horrible, horrible case. But when you hear that, I'm like, wow, I'm really weak in NRP. And that's going to come back and bite me unless I address it. I need to go do the course. I need to do the course. I need to study it. I need to read the book. I need to practice, because that's a vital skill. You know, there are some things we do that are just absolutely vital. They're high consequence, but low volume. You may never see it in your career, but when it's there, you've got to know it like that. And so focus your training on those things, and those are the ones you do repetitively. That's why we do airway every year. We don't do a ton of airways, but boy, those are the ones you want to have a mastery of.
Do you guys have any questions for Dr. O? Thoughts?
It's nice to meet everyone. A lot of new faces.
Well, he'll be here for a bit. We'll probably go grab some lunch before too long, but introduce yourselves if you haven't, and thanks.
Let's get a good call. I welcome gunshot wounds, hypothermics in the park.
Yeah.
Overdose too.
Overdose.
If Dr. O's here, weird shit tends to happen.
Suicide attempt.
Yeah. Scott and I rolled up